lecture by Dr. Aileen Davis, world-leading expert in patient-reported outcomes from a position as a senior scientist at Krembil Research Institute and University Health Network. For introduction, I'll have documents about Aileen. But before that, just a reminder to the audience, please post your questions on the question answer tab.
Thank you, Mohit. Yeah, this is a special moment for us. You get entitled this talk, Awe ad Quovala. If you remember your Latin, that is hail and farewell. So we'd like to both celebrate this moment in Aileen's career with a great deal of thanks. In addition to being a senior scientist in the Krembil Research Institute, Aileen is a professor in the Department of Physiotherapy and Surgery, also in HPME in the Dalla Lana School of Public Health, and in the Institute of Medical Science and Rehab Science. So her academic purview extends very widely through the University of Toronto. So I'd like to pass this over now to Lisa Badley, friend and mentor of Aileen for many years, for an introduction. Thank you, Lisa.
Well, I'm delighted to introduce Aileen's talk. You've already given a mini bio, so I'm going to be brief. I've known Aileen, it must be for at least 2 decades, if not more. Our careers in arthritis together. It's been a delight working for her. So as most of you know, and you've probably already heard, Aileen's was trained as a physiotherapist. And she's worked in 2 areas. She spent a significant part of her early research career in a PhD and gained an international reputation in that field. And it was their loss and our gain when she transferred to arthritis research and joined us here at the Western. I can't remember exactly when, but it was, as you guys have already said, Aileen is an internationally recognized expert in outcomes and evaluation research, which is really the cornerstone of evidence-based medicine. She's announced, I mean, I think it goes without saying that she's an outstanding scientist and really worries about that, I know, because we've worried a lot together. In her research, she's been committed to improving outcomes of people with arthritis and understanding not only that experience and what influences those outcomes. So given this, her research spans a wide range from quantitative to qualitative. It's unusual that somebody spans that range. And just to hit one highlight, most recently, she was instrumental in bringing the Good Living with Arthritis to our environment, and it was also evaluated, so we know that it works and shows long-term benefit. And it's now been implemented throughout the country. And Aileen, and this is one of Aileen's major legacies, although I think she's probably a bit of an unsung hero there. Aileen's retired, and she's technically already retired, but I do know she has a number of arthritis projects and collaborations underway. And at least in the short term, we'll continue to influence the OA community by being on the board of OSCE and being associate editor of Osteoarthritis and Cartilage. And on a personal note, Aileen, I have highly valued and enjoyed my various collaborations with you over the years. I'll really miss having you around and having you looming to my office and saying, have you a minute? And I wish you a long and happy and healthy retirement. And while I guess this is your valedictory talk to us, I hope this will not be the last time we hear from you.
Thank you very much for your kind words, everybody. So I have logos on my first slide, basically just to acknowledge the organizations that have funded my research along the way. And what I'm going to do is try and make this a little bit fun. It was a difficult talk to put together and made me do a lot of reflecting. So I'm going to tell you a little bit about how I got started, give you some snapshots of some of the research for my research themes and what I think my contributions are, talk about how I think this was made possible, and then finish off a little bit with some of the new adventures, and I should put new in quotes. So how did I get started? Well, people have alluded to the fact that I'm actually a physiotherapist by clinical training. And I worked at St. Mike's clinically, essentially for my first 6 years. Except, I have to tell you, was probably one of those annoying kids who constantly asked why. I've always got to stop and turn the leaf over because there might be something interesting underneath it. And I think that's still a big part of who I am. And so the first 6 years that I actually worked after physio school, I traveled for a little more than 3.5 of that. Spending 18 months in New Zealand, Australia, and Asia. And I just have always had this thirst to learn. And I came back to St. Mike's, which was at the point in time when Bob Bell was there and the sarcoma program started. And the ministry decided to consolidate all the sarcoma work to Mount Sinai Hospital. And so I was senior on the outpatients department at that time, and I pretty much decided that a pure admin route was not something I foresee for my long-term future. I just wasn't the administrative person overall. And Bob Bell asked me to move to Sinai with the sarcoma program as a research assistant. And I said, fine, but I had zero interest in doing my master's. And Bob was very insightful, and he just said, oh, that's fine. He said, you know, you're bright enough, you're curious, you'll work hard, you don't need to do a master's. And I went, oh, okay. So like within 6 months, I said, I really need to do a master's. And then I said, I really need to do a PhD. And sort of that's how it evolved. And I stayed at Sinai working with the sarcoma program until I actually moved to Toronto Rehabilitation Institute, which was not part of UHN at that time, in 2001, and progressed to a senior scientist there. And then I came to what was the Toronto Western Research Institute, and then Krembil in 2005. So I had a little bit of a winding road, and probably not the usual course for most people. So my research themes, which Lisa a bit alluded to, is really, I started at a time when patient-reported outcomes were really being recognized as something that was mandatory as secondary outcomes in clinical research, but also to start to think about measuring these in clinical practice. So I had very much a development and testing and application component to my research. But that was a means to an end, because what I was really interested in was understanding modifiable predictors of these outcomes, so that patient outcomes could be improved, and then moving into some intervention type work, particularly from the idea of implementing evidence-based care. So not so much the person who built the evidence, but implementing what evidence was there. And I did this initially in the context of sarcoma, and then of course, osteoarthritis more laterally. So the first thing I did in terms of patient-reported outcomes, which was part of my graduate studies, was the development of something called the Toronto Extremity Salvage Score. And this was a measure of physical function that I developed using input from patients and clinicians, which is common now, but back then was quite novel and just sort of being understood as being important. And this was a measure for evaluating outcomes for people who underwent limb preservation surgeries for soft tissue or bone tumors. So to put who that group of patients is in context, Terry Fox had a sarcoma, he had osteosarcoma of the bone. He had an amputation, but the large majority, 90 to 95%, actually have these massive tumors removed and their limbs reconstructed. And this measure, which has been translated into 13 languages and is still used today for clinical trials and clinical monitoring, really kind of came to the fore because it was applied as a secondary outcome measure in the SR2 trial, and I'll talk about it in a minute. Some other patient-reported outcomes I had a lot of involvement was the development of the DASH, or the disabilities of the arm, shoulder, and hand, which some of you probably know. And then the work to develop the short forms of the knee injury and hip injury and osteoarthritis outcome scores. And I was also involved in the development of the neck outcome score. And then I've had numerous graduate trainings over the years. So I've got a long history in the methods and the development and application of these measures. So I mentioned that the test, or the Toronto Extremity Salvage Score, was a secondary outcome in this randomized trial for people with extremities, so arm, leg, soft tissue sarcoma. And this trial was a bit unique in that it wasn't about disease outcomes, but rather it was about morbidity. So people with soft tissue sarcoma are routinely treated with a combination of surgery and radiation. And this trial looked at using radiotherapy preoperatively versus using postoperatively. And that maybe sounds like a small thing. The issue is with preoperative, it's only 50 gray dose, which is much smaller than what happens routinely in the post-operative phase when there's 66 gray used. And this difference potentially impacts the amount of tissue damage to the remaining normal tissues. So this was about morbidity. The primary outcome was actually the incidence of wound healing complications, with the anticipation that the preoperative group would have a higher incidence of wound complications. But there were a number of secondary outcomes, and particularly for me, the quality of life and physical function and the RTOG, or the radiotherapy late effects, were the things of interest. So, not surprising, you can see the red numbers at the bottom of this slide. We in fact found that 35% of patients had significant wound complications, i.e. return to the operating room, versus 17% in the post-op group. So definitely pre-op radiation had this impact on wound complications. And this finding was such that we were actually stopped at interim analysis. But the thing that was interesting was when we followed these people through the year 1 and year 2, although people's function was impacted and not as good in the preoperative group early on because of these wound complications, this equaled out and they did equally well as we got into these later time points. But this graph shows the impact of that higher radiation dose. So this is the percent event-free rate. So in the solid line, you can see the preoperative radiotherapy, where there is a much higher event-free rate in terms of the amount of subcutaneous soft tissue fibrosis. And so this isn't just that tissues are a little bit hard. These are hard, indurated tissues where we start to see a bit of contracture of the subcutaneous tissues in that. And the problem is, as people get into this, they start to lose function because they don't have the flexibility in their soft tissues. They start to lose range of muscle or motion. Muscles don't work properly. So it actually impacted function. And what we started to see was, as people started to get into that 3 to 5 year and longer follow-up, that they actually had worse morbidity from the post-operative group. So the impact of this was that preoperative radiotherapy became the standard of care because of this lesser morbidity. And the wound complications actually can be managed if you're, at the time of surgery, preemptively using soft tissue transfers and various flaps and things. So you can actually manage these wound complications fairly well. And the pre-op reduces the treatment morbidity. Now, radiation techniques have evolved since this study, but this preoperative radiation has been sort of the standard against which all these new technologies have been compared. So this study had quite an impact, actually, in terms of how patients were treated. So I moved from sarcoma. I still did a little bit, and I still help a little bit with some oncology stuff, but it's a small field, and I really realized that I was not going to be able to build a complete scientific career. And I was also a lone wolf. There was nobody else doing patient-reported outcome-based work in that. And so I started following my interests in musculoskeletal work and got much more involved in some of the osteoarthritis. And I've put this up simply because this is how I kind of think of osteoarthritis and a framework for management, where we have sort of these pre-OA, where we've got people with injuries who are predisposed to developing knee OA in particular, and then people getting into mild, moderate, and more severe symptoms, plus minus how the radiographic features march with that. And I'm going to talk a little bit about I'm going to start at the back end with some of my total joint replacement work. Then I'll talk a little bit about the guideline-based education and exercise, and then touch on the OA risk management work post-injury. So the series of total joint replacement studies that I did had a couple of things we tried to build over the period of time. So one was to understand the trajectory of recovery in the year following total joint replacement, and particularly in terms of understanding how pain function and engagement in higher demand activities are related. And I sometimes call these higher demand activities social and community and involvement, participation restrictions. I mean the same thing when I use these different words. And from that data, we then actually started to look at factors that affected engagement in these higher demand activities and leisure and social activities, and then moved on to some work trying to understand satisfaction with outcome. So this was a study of hip and knee patients, and combined there was just over 900 patients. There was 428, I believe, knee patients. And so you've got 4 graphs here. So physical impairments, and I work a lot from the International Classification of Functioning framework. So physical impairments in this context was by and large pain. Activity limitations are things like mobility, activities of daily living that we usually do, and then that participation, the social community participation, those are more our leisure social activities, some of the instrumental activities of daily living, like going on trips and things like that. And the mood component is subclinical depressive symptoms and anxiety. And really what these graphs show you, so lower scores are better in all cases. The red lines are the people who had a hip replacement, the red are the hip replacements and the knee replacements are the blue lines. And what you can see for the physical impairments and the activity limitations and the mood is a very similar patterns. So always the hip patients have a little better scores as they get into follow-up than the knee patients. And what we see is quite a sharp improvement out to the 3rd time point, which actually represents 3 months following surgery. And then the gains are quite incrementally small after that, but there is definitely still some ongoing improvement to 12 months. The participation restrictions are a bit different pattern. And in fact, what we actually see is in that immediate period post-surgery, which is probably understandable, people actually get worse. They're doing less in terms of getting out in the community and the participation components. And then gradually they start to improve in this, and they again by 3 months sort of plateau, and they've had their big gains and then they start to plateau, but again some small incremental gains through 12 months. And the hips and the knee patients look very similar. So we wanted to understand how the pain, the function, the higher demand activities, mood, all were related to each other. And this is a diagram from a path analysis, so it looks quite complicated. And basically the different colors represent the strengths of the relationships. But there's a couple take-home messages from this. And basically, the bottom line is, so if we look at pain, functional limitations, or participation restriction, where you start and every subsequent time point is linked to each other. So how I am pre-surgery impacts how I am at 2 weeks. 2 weeks impacts 1 month. 1 month impacts 3 months, and so on. What we also see, though, is the relationships of pain to functional limitations and subsequently to participation restrictions. And what's also really interesting is that there's this lagged relationship. So the lagged relationships are those dotted orange lines. And essentially what we're seeing there is that there's a negative relationship. So the higher your score, say at 1 month on pain, the worse your functional limitations score is going to be at 3 months. So there's this lagged relationship across time. So what does all this mean? So essentially, the bottom line is that if we're looking at outcomes for these patients, we need to target all the constructs. We need to deal with the pain. We need to deal with the functional limitations, mobility, but we also really need to be addressing these participation components. And what we need to think about is the timing and provision of interventions. So if you don't deal with the pain in the early periods and get that working well, and then the function components, you're not ever going to have the impact on the participation components. And so the timing piece is important. The other thing to mention is that care pathways tend to focus very much on that short-term period. So people have their surgery. They usually have physio for somewhere around 8-10 weeks, and it's usually about 6 to 8 treatments. And then basically they're sort of largely left on their own just with periodic surgery follow-up. And certainly during this period, that's what it was. So it may be, given what we saw in these pathways, that in fact, the short-term follow-up is needed to be rethought. I'm just going to go back a slide because I want to point out one other thing. So if you look at participation restrictions, the other thing we see here is that the pre-surgery value impacts at 1 month, at 3 months, at 6 months, and 12 months. So where you start impacts along the whole way, taking into account all the other relationships. And this was important to us because when we started to look, so this was based on how limited people were on their participation restrictions. What we did also is we had the ability to, using the Jetty measure, to look at the frequency of participation in higher demand activities. And basically, there was no difference from pre-surgery along any of the time points. People didn't improve, they didn't engage more. And this is problematic because we know these higher demand, these participation components are really important for healthy aging. It influences the social interactions, the self-management of personal affairs, mental health. It has a negative impact on healthcare utilization. So we were really curious as to why the frequency didn't change. So I worked with colleague Fiona Webster, and we did a qualitative longitudinal study. Longitudinal qualitative is a little unusual, with 30 patients. And we found 4 main themes affecting people's frequency of participation and their actual participation in these kinds of higher demand activities and social leisure things. And these were losses due to OA prior to surgery, the experience of surgery as an intervention, which I'm not going to talk about, multimorbidity and multiple painful joints, and then the sociocultural context. So in terms of losses due to OA prior to surgery, most people had actually given up or modified their participations in various activities that they'd enjoyed and valued, and they'd given them up because of their OA problems prior to surgery. So they've gone into this new normal in this window before their surgery of doing things differently. They changed the activities they engaged in. They changed oftentimes even some of their social circle because they wanted to do things with people where they could quote unquote keep up. So all of this had happened before surgery. The other thing that happened is people described the dramatic improvement in pain, but what then they also became aware of was that they had other symptomatic hips and joints limiting their activities. The other thing that was surprising to us that arose in that first year post-surgery Some was associated with the surgery, but a lot not, is these people developed a lot of new comorbidities. And we know they're, you know, generally on average in their early 60s, but it was striking how many health issues arose in this year. The other thing that arose was that there was a lot of things going on in people's lives, both negative and positive effects that impacted their return to activities. And some of this was a change in family composition. So the death of a spouse or a partner, or suddenly they had major caregiving roles. Their support network might have changed because of illness of a good friend. Some of them, their geography changed. They sold their houses, they moved to condos, but not necessarily in an area where they had their social community. And for some of them, their socioeconomic status became problematic. So what this data actually showed us that, you know, pain and mobility issues had resulted in people giving up many activities long before they had their surgery. So this whole idea of returning to activities wasn't really germane. They dropped to this low level of participation pre-surgery, but they've done it in the context of changing their social milieu and what have you already. So what they were going back to was really this low level. It's not like they were going to necessarily enhance that. The other thing is this experience of health and health care is complicated, multifactorial. They had many other competing demands that also interfered with their ability to become more active and more frequently active. So when you start getting into evaluating interventions in the context of engagement and activity post-surgery, it really becomes very, very complex and challenging due to this intersection of socioculture and other factors. We had quantitative data from our cohort where we looked at our relationships of outcomes. And we looked at both the hips and the knees. I'm just going to talk about the knees today. And we had something called the life events scale. And this quantifies positive and life events. So a positive event, you know, might be something like, you know, a friend moves closer and now your social circle's expanded. A negative event might be a death of a spouse or a new major illness or what have you. So if we looked at the positive events, there was 199 positive events overall reported by 311 participants. So that's about 0.6 per person. In the group who reported increased frequency and activity, if you had decreased frequency of activity, this was only about 0.41 per person. So it seemed like having more positive events was something that helped to become more frequently active. The negative events far outweighed the positive events. So for people who increased their frequency, they had about 1.3, 1.4 negative events per person, whereas the people who decreased their frequency were more up about 1.9. So it seemed like these positive and negative life events had an effect. And we actually modeled this. And what we found was that the frequency of engagement in these activities prior to surgery impacted whether you changed in your frequency of engagement in a positive way. If you had negative life events, that you were more likely to decrease your frequency, and for patients who had complications from surgery, they were highly likely to decrease their frequency. So if we put all the qualitative and quantitative together, the quantitative results largely supported what we heard qualitatively. And these multifaceted complex interactions pre and post surgery impact people being active and engaging. And what it really speaks to is the need that there's not going to be a one size fits all here. It needs to be a personalized approach and to include care strategies to mitigate some of these things happening in people's life context in order to help them be more active following their surgery. I think the other thing that the data raises the question of is how much loss in terms of activity and being able to be activity becomes a point when it's too much, that we've waited too long and we may potentially be influencing that whole concept of healthy aging. So the last thing we looked at was trying to understand predictors of outcome satisfaction. And this is, again, another complex model. The short answer and the important piece here is, and I don't show the time component, but people need, following total knee replacement, to achieve the important improvements in pain and function related to mobility, daily activities by 3 months post-surgery. If they don't achieve that, they're going to be your group of people who are most likely to be dissatisfied with the results of their surgery. And it also probably speaks to the fact that they need to be on a slightly different care pathway. And I talked about this care pathway being standardized, and standardized is probably good for 90%, 85%. It's the rest of the people who need to be able to move off the pathway. So I moved from total joint replacement to the non-surgical component, the GLAD program. So it's 2 education and 12 supervised exercise sessions, largely in a group format and now virtually in a group format, for people with symptomatic hip and knee OA. And the results are quite good. And this is data from a paper that's just submitted. So this program was developed in Denmark. We brought it to Canada. Subsequently to that, the program moved to China, to Australia. It's now also in Switzerland and New Zealand. And I think there's another country, I forget which, about to start. But so this is looking at comparative data from Denmark, Canada, and Australia. So Denmark started in 2013, Canada late 2015, Australia about March of 2016. And you can see the number of participants there in the program. Very typical of people with OA, overweight, about 65. Most complain primarily of knee problems. And this is just showing the change in pain, the 50-meter walk test, 30-second chair stand, and the Who's and Who's quality of life subscales. From baseline, depending on the country, we saw about a 26 to 33% improvement in pain intensity. The walk test in terms of time improved by 8 to 12%. The chair stand, which is really a measure of lower extremity strength and some balance stuff, 18 to 30%. And we saw the quality of life subscales improve 12 to 26% from baseline. These are pretty big effect sizes for this program. So depending on the outcome in the country, these effects range from 0.37 to 1.0. So moderate to large effects. And these are as good or better than you're going to get from any NSAIDs. Satisfaction's very high. People really like this program, and a lot of people indicate they continue to use it. And as Lisa mentioned, this program's actually now moved to clinical implementation. I did the implementation science research part of it, and then it transferred over to the arthritis program, and Mike Zywala and Christian Valletta are now working with Bone and Joint Canada for the clinical implementation and registry support. And as of the end of December last year, the program was in 9 provinces and 1 territory, and there'd been over 3,000 patients through the program. So absolutely a huge success for patients. Then the other part I moved to was this interest in knee injury and the fact that about 50% of these people, somewhere within 8 to 12 years, generally start to get some symptoms of knee OA. And we know there are modifiable risk factors of knee OA, so making sure you stay active, but active in appropriate kinds of activities, i.e. limiting weighted pivoting type motions and things. So we started this off with funding from the arthritis program, actually, to understand what healthcare professionals told people about having their injury and potential for arthritis. And the main messages we heard was that orthopedic surgeons pretty typically at the time of surgery had the conversation with the patient about developing arthritis, because even though the ligament's reconstructed, it doesn't prevent the arthritis. Primary care sports physicians also had conversations early on, and they talked about it a little bit more through the period of 3 months to 6 months after the injury, but definitely the proportion fell off over time. The physios who actually spend a lot of time with these patients as they're rehabbing and that, only 33% of them ever talked about OA and OA risk factors. So this really sort of set up a disconnect for us. So particularly because although all the health professionals thought they were appropriate to talk about OA and managing OA risk factors, and 98% of the PTs thought they should, only a third of them ever talked about it. So for us, this was sort of a low-hanging fruit and something that seemed like a need in terms of thinking about the clinical care overall for these patients. So we moved and got a CIHR grant to develop a care pathway intervention and evaluate its feasibility. And this work includes interviews with patients. There's a survey. We conducted a workshop at the end of February. And basically from all these inputs, we have the content and the necessary delivery approaches of the intervention. And so we're in the process of pulling all this together and developing it with the idea that the feasibility study testing will start towards the end of this year. And this work will continue on. Other members of the team will take over, and I will continue to collaborate with them. So how did this happen? How did I have this career? I mentioned Bob Bell before, and I will tell you, mentors, and it's funny, Lisa, you were on my master's thesis committee, so I knew of your work before that, but that was where we really started spending time together. So I have to give a lot of credit to Bob Bell, who had a vision, and he basically let me fly. Jack Williams, who was another one of my major mentors and my PhD supervisor, often described that Bob just basically gave me a dry lab and let me come up with an idea and try it out and do it, and was supportive. Jack was instrumental in some of the push with my measurement work, but he has a much bigger view world of research and what have you. So he also was somebody who was wonderful in terms of that big perspective of things. And then, as Lisa said, as I came to the Western, she became very much a collaborator, but it was back to my asking my whys and my frequent visits to her office to say, do you have a minute? What do you think? So I'm well-traveled. I've been to 29 countries. I actually have collaborators from 14 countries, and I'm not going to go through all these names, and I have to tell you I quake a bit because I'm sure I forgot somebody's name. But what I really want to do is give you a sense of how strong and the breadth and the support I got from all these various collaborators from the different projects. And I've only touched on a few projects. There was a whole bunch of other things I didn't even talk about today. The one thing I do want to call out is my research staff. And I will tell you, they, in my mind, are also the make or break of your projects. Their dedication, their hard work, their attention to detail, they were a huge part of the success. my trainees also. I often think how much I've learned from all of them, and I think back to my training and what these people have now in terms of the ways they think, the skills they have, and man, things have moved a long way, which is awesome to see. So I am still traveling. I do and so I'm now trying to get my motor memory back for playing. I've also started long distance cycling again, and I've started drawing, and I'm actually quite love it, and I'm addicted to it. I want to pay forward those brushstrokes to others. Thanks very much.
Thank you, Aileen. That was terrific. There we go. Activated here. Okay, so questions at this point. Here we go. Perhaps I could start off, Aileen, about your trajectory of almost every outcome variable, like mood, participation, really differed quite significantly between total hip and total knee. You've looked at these patients in depth for a long time. I assume the demographics are quite different, but what do you think contributes to those big differences between hip and knee surgery?
So I actually, the demographics aren't so different. I think we maybe see a little more in terms of people being overweight or obese with knee OA than hip, although that's a bit questionable. I actually think that the difference in the outcomes comes down to the difference in the complexity of the anatomy of the joints. And I think how different and difficult the technicalities of the surgery are. And I just think the knee's a much more complex situation. I also think that one of the things we don't pay enough attention to is these people, that means their soft tissues have shortened. And I don't think we pay enough attention to trying to work and think about the impact of that on the overall function. So I think there's subtle things and not easy to measure, but I think they do have a big impact.
There was one comment, and I hear, Aileen, they love that last slide with the quote again by Chris Ensor.
Yeah.
That's a wonderful concept. That was a beautiful one.
Yeah, I agree. I think it just sort of, it's got that art thing, but I think it really describes what we get as being scientists and what hopefully we pay forward. And I have to tell you, people sort of will say, well, what do you like about being a scientist? And I just kind of go like, it's a privileged world. Like, who else has a job where you have a question, you come up with a cool idea, you can get funded, and that's your work, right? Like it's really a privilege.
When you're talking about the effect size of the GLAD program, I mean comparable to NSAIDs, if you factor total joint replacement, how close are we to positioning ourselves for a randomized control study of GLAD versus total joint replacement?
So total joint replacements, the effect sizes are generally 1, 1.2, 1.5. They're really big. There has actually been a randomized trial of the GLAD program versus total knee replacement. It was done by Søren Skou out of Denmark. And they basically took people and gave them the option to go into GLAD. They could still have surgery down the road if they wanted, or they could, they were randomized straight to having their knee replaced. So not surprisingly, so both groups improved a lot. Mm-hmm. Not surprisingly, the group who had knee replacement had bigger improvements in pain and function overall. Uh-huh. But they also had adverse effects. There aren't really adverse effects from exercise in the same way as surgical complications and things. And none of the people in the exercise group, and they've now done the follow-up just past 2 years, none of the people in the exercise arm yet have said they want surgery.
Okay.
So So that's good. The question is, and it sort of alludes to the stuff we talked about, is when's waiting too long that people have given up too much. So I think it's great. And particularly a 50-year-old, if you can buy them time, is wonderful. But you need to monitor them and not wait too long.
Thank you. So next question is by Dr. Amanda Ali. Thank you for sharing your path and congratulations on a successful career. Questions about the outcomes of the GLAD program. The effect sizes are impressive. Could this result from a selection bias, where those who participate in programs such as GLAD are more self-driven and therefore more likely to benefit from the self-management interventions? Do you think these effect sizes will persist in broader population?
So I think one of the challenges we've always had is, people have high self-efficacy or want to try and help themselves are the people who participate. I guess so first of all, the other thing I didn't say, those were the post-program outcomes, but those outcomes persist through 1 year. They don't really degrade, which is good news. And I guess what we normally think of as this is a registry, it's not got a control group, although there's been so many randomized trials showing exercise works in terms of reducing pain. I guess the thing that I would say is the effect sizes we're seeing when we had small samples. So when we did the pilot with like the 47 patients in Canada, when Denmark did their pilot with I think they had 26. And then as we've gone, we haven't seen these effect sizes degrade. And so, like maybe there's a lot of people who are just really highly motivated, but generally when you start moving into those kinds of samples and getting broader, you would expect those effect sizes to degrade, and we're really not seeing that. So could well be, but it's still pretty successful implementation and probably bigger effects than any of the other implementation programs I've seen been able to maintain this. I mean, Lisa, can you think of any other things that have gone to full-blown implementation that's been able to maintain effects like that?
I can't think of much in the non-surgical, non-medical side that has gone to full implementation, because most things have been, there's been lots and lots of successful studies with really good outcomes, and then they've just fizzled because they haven't had the support. There hasn't been the implementation research, because it's a whole extra stage, obviously, to get things working in practice. I mean, this is one of the big achievements that GLAD not only was developed, evaluated, but actually has been successfully implemented and customized to different countries, because it's delivered in slightly different ways in different countries, which is something that Aileen didn't highlight. But to me, she did a lot of work to customize GLAD, the core of GLAD, to what will work in Canada.
Yeah, and I mean, I had to develop the training program to teach the therapists to deliver the program and stuff. And I mean, it's even like Denmark, they have a little bit of variability in their healthcare systems, but not a lot. I mean, Canada is like dealing with every province is an individual healthcare system, and we had to be able to maneuver and function within that, right? So that was a ton of work, to try and just be able to be flexible and figure it out.
That's why, I mean, Aileen was an unsung hero, because a lot of that work was not seen, but it was absolutely crucial.
We have a question, Aileen, from John Acker. He asks about the benefits of early post-op discharge with respect to pain and function. Do you have any thoughts on that?
In terms of the total joint replacement.
Right.
So I think the piece that is critical is that acute period of pain management is really important, and that people need to understand the need that movement actually helps pain. And actually with Karen Davis and Eva Bruce, where it'll come out soon in current concepts in rheumatology. We've just done a review of why exercise actually improves pain, the mechanisms by which it helps. So I think early discharge works as long as people are at a level of pain control that they're able to get moving and they understand that, and they understand the piece of that early period, getting the pain under control. And by early period, I mean those sort of first 3-5 days, and then start to just doing a bit more and weaning off the pain meds. So being in hospital and laying around is not a good thing, for sure.
The next question is by Trevor Birmingham. Great presentation, congratulations. What is the status of funding for exercise programs like GLAD Canada?
So it a little bit depends where you are by province. By and large, rehab is in the private sector and it's pay out of pocket. Alberta up front, through Alberta Health Services, put funding in place for some of the programs. So they've had from the very beginning that mix. And it's actually interesting. There are actually some incidents now with some of even the insurers are coming and saying they want their patients in the GLAD program and they'll pay for it. Ontario, the province, did a program where some of the LHINs actually had public funding to deliver the program. Now, we had to put it in, some of the private clinics had to do contracts to deliver that. And that was in the process of being negotiated of how it was going to carry forward, because it ended the end of March this year for that funding envelope. But then COVID hit, and so the government's not dealt with any of that, but it is still on the table in Ontario. One of the things that happened in Ontario is they did a health technology assessment that showed the cost effectiveness of the GLAD program, and that was actually, so arm's length, but with that, the ministry has been very supportive, so we'll see what happens as COVID goes forward.
Well, Aileen, we are at 9 o'clock now. Well, on behalf of the Krembil Research Institute Arthritis Program, as well as the University Health Network, just want to congratulate you on an amazing career. And I think it's a big thank you from the entire musculoskeletal field. And thank you for taking out time to speak today, and wish you all the very best in your next phase. To the audience, thank you for joining us today. Please join us next week for lecture number 8 by Dr. Tuhina Nioji from Boston on pain phenotypes. Again, thank you so much, Aileen. Good luck with everything.
Bye-bye.
Great. Bye-bye. Thanks.
Goodbye. See you, everyone. Bye-bye.